The last talk for today is our very own Neil Stollman, who serves on the board for the NCSCG. He is very prolific with American College of Gastroenterology as well as AGA. I'm sure you've seen his names on multiple guidelines and papers. But today we have the pleasure of having him speak about COVID-19, obviously a major topic of interest, and in particular, now that we're over 7 months into this pandemic, what are the long-term impacts on our GI practices? So thank you very much, Neil, for speaking with us today.
And thank you, Nick, and course directors for having me here. Yeah, this talk has been kind of a strange talk. This, as the course directors mentioned, we started planning this meeting before COVID, actually. And, I'm usually talking about poop and fecal transplants and things like that. But then we thought, all right, let's not do that over lunch because that will ruin all your lunches. So then I was going to actually give a talk on advocacy. I spend a fair amount of time in DC and for the college working on advocacy and moving sort of legislative needles forward. And then this happened, and in fact, this big advocacy meeting I usually do in April didn't happen. So we kind of pivoted yet again to a different topic. And what I'm going to try to cover is really not science. This is much more philosophy or art, and sort of talk about what's coming basically in the next perhaps year or so. I apologize too, because I saw that both John and Drew were wearing blazers for you guys. I'm an Oakland boy. First of all, I'm not sure I own a blazer anymore. But I have more books behind me than they do. So there's that. This is who I am. That's my email there. And I encourage actually people to use it. That's my Twitter handle, which I'm not all that prolific on Twitter, but I am pretty good on email. And if you have any questions about any of this stuff, I would encourage you to email me. I'm also, for literally one more week, the chair of the College Board of Governors. And I'll put in a shameless plug. In 1 week, I term out of that job, actually, although I'll be staying on the Board of Trustees. I'm going to put in a shameless plug right now for next week. I know you're spending your time with us today and tomorrow, but starting on Friday, you have an option to hang out in this meeting as well, which will be, I hope, as good as this one. I hope we at the ACG can equal what we're doing here today. It's free, I will add. If you are a member of the ACG, that meeting is entirely free, like this is. And if you're not a member of the ACG, then we better talk, because that's a problem. All right, so let's talk about where we're going. And this is just kind of the time frame I wanted to talk about. And I actually just added that graph on the bottom yesterday, because it really does change things. There was everything before March. In fact, in March, this picture behind me is from a research library in Amsterdam. And I was actually in Amsterdam where my daughter was studying and kind of got called back, as did she, sort of more abruptly than we'd anticipated, because that slope was just kind of going up. And then we kind of thought, okay, well, it's going up, and then it started going down, and that was kind of be where we were. And as you can tell, there was obviously the second peak late this summer in August and the like. And unfortunately, we thought, well, that would be done. That's our second peak, and we're on our way down. And as you all probably know, we're beginning a third peak, or the first peak is still going. You can argue about the semantics of that, but this certainly ain't going away. And we're 7 months into this, and it's still an absolute catastrophe in so many respects, professional and personal and the like. But what I want to talk about is sort of what I think 2021 might look like from our perspective. And I'm not going to talk about sort of COVID, the disease, and that was another talk we talked about, GI manifestations of COVID. That's not what I'm going to talk about today. What I intend to talk about is, I think, what this means for our practices and our profession going forward. Again, it's hard to see. We can see what we can see, but I would have thought we were already at a different place today. I think many of us thought we'd already be at a different place today than we are. And in fact, we're at a worse, psychologically, it feels like we're making some progress. We're much worse than we were in March, as you know. I mean, the numbers, if you just look back here, the numbers are much worse. So we're not really getting across this bridge just yet. And I don't think we can see where the end of this bridge is, unfortunately. It'd be nice to be able to see ahead. I'm going to talk for a few minutes just in some terms of some data that we collected at the ACG. Actually, the ACG has a practice management committee that does exactly this kind of stuff. And early on, the practice management committee came out in April and did a big survey of 300 or 400 members. Actually, it was a large survey, and it covered the whole country, different practice settings, academic, private practice, military, and the like. and tried to get a snapshot in April of what was happening. And those red boxes are basically places that were closed down. And that's not surprising to any of us in California. We closed down, my practice closed down for about 6 weeks entirely, maybe 5 weeks in sort of mid to late March into mid to late April. We're obviously open again as most people are, but the coast were the initial problems. In the middle of the country looked good. Of course, if you've watched sort of the moving targets on the Washington Post and New York Times, you see that right now the middle of the country is far, far, far worse than the coast. So then we redid that survey in June, actually, and because we thought, this curve went up and it went down, and it was really logical to say, well, this is what happened in the middle of this pandemic. Now let's look at what's happening now that this pandemic is winding down. Problem, of course, is we're not winding down, obviously, and we got to redo this study because we're now in yet another kind of problem point. But you can see that in April, there was a real problem. I mean, that's the take home here, is that literally half of our practices laid off at least a quarter, if not more, of their staff. So we're operating at less than a quarter of staff. That went up in June, and we don't yet have kind of current data. And more than half of people were not seeing patients in their office nationally. This is a large national sample. 60% of practices were only 40% were seeing some patients in the office. That number went up to 80%, but that's not only office. That's sort of still a hybrid. And for example, my practice is doing some things remotely and some things in person, and we're still nowhere near back to a normal office-based practice, certainly. And we're not even back to a normal endoscopy-based practice. And I'm sure many of us are not as well. And this is practically important, particularly for private practitioners. I mean, salaried docs have a slightly different impact on this, but for private practitioners, everyone was losing money basically early on, and people were not taking salaries, and the expectations were really quite significant for them. Expectations were a lot better in June when we looked a second time, although again, the psychology of June was rather different. I think we really thought we were downsloping, and the psychology may well be different now. And I don't think this is a crazy metaphor. You're all familiar with Kubler-Ross and the cycles of grief. And, on the left is denial. And without getting too politic today, I still think some of our politicians are in denial that this is actually something. And certainly there was anger. There was really hopelessness and depression and the like. I'd like to think today that where we are is at this point where we're telling one story. We're reaching out to others. So I think today's intent is really to fit ourselves right into this little bargaining box here. And that's what I hope we can do in the next 15 minutes or so and have some conversation about. What I really hope, of course, is that we can move over to a new place and moving on. And that's what I'm going to try to hint at for the rest of this talk. So I'm going to divide my conversation into a bunch of different things. There are sort of regulatory concerns and financial concerns that clearly impact what we're doing. There's people concerns, and that people concerns are clearly not just our patients, which is front and center and should be front and center, but there's also our staff, and that turns out to be, I think, more important than we might have thought. And I'm going to talk about patients and staff as well. So the regulatory stuff changes, and unfortunately, I can't give you much closure today because in a few weeks, we're going to have the results of an election, and that is assuredly going to change this outcome. But right now, we have sort of guidance from the federal government. And it really is guidance. It's generally not as dominant as local regulation. So just be aware that what the CDC and the White House says is actually not what we're generally subject to. We're much more subject to local regulations, and what we do in Santa Clara County and Alameda County and San Francisco are driven by our local politicians and regulations and public health people. And I'm ecstatic that we live in such a place because largely we're making rational decisions here. There's obviously financial stuff that is federal. The financial impacts, the PPP and the CARES Act are also going to be impacted by what's coming up in early November. There is a lot of talk actually of expanding the PPP program again because this has gone on much longer than we thought. Again, we all kind of thought this was going to be this bucket and it was going to happen and then it was going to be over. And assuredly that's not true. And people are still financially suffering with quite high certainty. This leads to the need to sort of change how you think about your practice's financial outlook. I think, my partner, Paul, who's somewhere on this call, we would look at stuff, once a year, perhaps, maybe twice a year, kind of look at where we're going and trends and spend some time on this, but we're not in a steady state. That worked when we were in a largely steady state and our changes were incremental and small. But obviously we're not in a steady state, and things are radically changed. Our expenses have changed, our income has changed. And I think that really means we have to start looking more frequently. And we talk about this in my practice now every 2 to 4 weeks, really. We're kind of rejiggering what we're doing. It's really changed the game for how we think about the timing of our practice. And while, we're talking about science and patient care today, money matters. If you're running a business, you have to keep that business going. And I don't think there's anything wrong with acknowledging that. And I've been in a bunch of different worlds, a university world and a VA world, and now in a private world. And it's part of what it goes to keep a practice open. So we talk about break evens, and break even and analyses are super important. You can't lose money for too long and remain a solvent business. You can lose money. We did lose money for quite a while, but you can't keep doing that, or you're not going to have a business to continue. And break even is not all that complicated. If one side is changing, you kind of got to change the other side as well. Costs are clearly up. There's no question that costs are up. PPE is expensive. It's crazy expensive. We're paying $1.25 for gowns right now in my practice, which used to be 12 cents, quite literally. And that's nuts, but true. And we're 7 months into this, and the fact that we can't get gowns made adequately is an absurdity, but is practically speaking true. Staff costs are going up, and I'm going to circle back to that a little bit on how we're dealing with staff. So your costs are going up. So how are you going to handle that? Well, you kind of have two choices. You can either get more per procedure. Your reimbursement could go up, and well, we all know exactly how much that is not happening. If anyone has a secret to raising their reimbursement, please let me know. But certainly in my practice in Oakland, that's not happening. And you can try to increase volume, but that's of course a rock hard place. We can't increase volume. In fact, our volume has gone down. We're operating at about 2/3 productivity in my practice right now because it's a small ASC, and we need to worry about distancing and room turnover and things like that. We cannot, in fact, be nice to operate at 120% of our prior volume, but in fact, we're operating about 80% of our 75% of our prior volume. So that's a problem, and that's not a sustainable thing. If your costs are up and your reimbursement is down, if that cuts into your profit for a period, that's fine. But at some point, if it actually goes below what your costs of doing business are, practices are suffering. And GI is fortunate. Obviously, we're pretty well compensated compared to others. But this is really a giant problem for private practice in America, and is almost certainly hastening the dissolution of independent private practices, because this hit has radically hit those people, and a progression towards sort of more owned practices and employed physicians has been accelerated by this, for sure. All right, that's dollars. Let's move on from dollars, but let's get to our people, our teammates, and our staff, really. So, these infection control measures, again, that, we bought some plexiglass barriers in March or April, and we thought that was that was a temporary measure. That's not a temporary measure at all. That's probably a permanent measure, or certainly a measure for the next 3, 4, 5 years. And I think I'll show you some data on that in a bit. But you're going to be buying a lot of hand sanitizer and a lot of masks and a lot of gloves, and keeping people apart, and have, barriers, markers on your floor for where people can stand. Those are not temporary markers anymore. You may as well buy the fancier ones, because you're going to be keeping them. I do think we're moving our attention, and I'm not giving a whole talk on safety. That we have a whole ACG playbook on that, on how to sort of do these things safely, and getting into air exchange and the real specifics of that. But I'll tell you, there's appropriately, I would say, a push to move a little bit away from surface decontamination things. I was on a webinar once where they were literally talking about spraying the wheels of stretchers with bleach and stuff. And that's fine, but that's not at all the way that this is happening. And really, we shouldn't be wasting our time and energy on that. People have called that hygiene theater, and Atul Gawande is a great sort of article about that. It's airborne. We know this, and we could have an argument about aerosol versus airborne and the semantics of the droplet size that are transmitted and the distances that those droplets can go. But this is largely not a surface transmissible infection, and all of the crazy stuff we're doing about surfaces is probably not changing that. We're not paying enough attention to our airspace and our ventilation, and I think that's really an important thing. In the vice presidential debate, there was all this debate over the damn plexiglass between these people who were 12 or 18 feet apart. That plexiglass was absolutely irrelevant. What was much more relevant, and the Mayo Clinic should have been paying attention to, is what is the airflow in that room. That really mattered far more. And there are lots of examples of that. And one that's been talked about is New York City, where I'm from. I'm born and raised in New York, and I do love New York. But New York's, sort of radically changed their subway. They actually closed the subway at night now to basically spray decontaminate the subway cars. And that's okay, certainly. But the Tokyo subway, by contrast, doesn't do that at all. What the Tokyo subway does, and Tokyo subway is a super crowded subway, what they do is very simply make everybody mask. And masking is mandated and policed and effective, and they are not seeing outbreaks. They are absolutely not seeing outbreaks. And I think we are sometimes missing the forest from the trees here by spending $1 million spraying bleach on a subway car instead of actually inhibiting aerosol transmission from person to person. Our workspaces matter too, and this is kind of a fascinating case from South Korea in a call center, and this is a particular floor of a large multi-story office building in Korea, and on the top of that graph is the call center. Actually, it's on the bottom side too. There's a big call center, and there's an index patient that's not identified, but it was somewhere roughly in the middle of that. And you can look, the people around in basically spitting distance, if you will, of that index patient in that call center, 50% of them got COVID. Infections. But if you look at even just the other side of the floor, it was very low. It was less than 5%, which may well have been background. And most importantly, if you look at the rest of the building, it was a large building, and nobody was getting it, basically. This was not from people pressing elevator buttons or opening, conference room door handles or things like that. It was proximity and shared airspace to another person. And I think we have to really work much more directly towards that rather than some of the other things we're doing. I saw this quote in an article about our professional future, and I love it. Staff meetings will be fewer, smaller, and shorter, and I wish I could take credit for that, but I'll support it because staff meetings should be fewer, smaller, and shorter. I think we'd all be just fine if that was the case. While that may be true of your staff meetings, that's not true of your team. Your team's got to get larger, and that's unfortunate at a time when reimbursement's going down. But you all know this. If you're employing people, if you're working in a private center and employing people, you've seen this every single day. It's disrupting all of your staff's lives for lots of different reasons. They're getting exposures. They're quarantining. We have staff out, not infrequently because a family member got COVID and they're out for 10 days now. Childcare issues are a huge issue for a lot of our staff. They're often young parents, and simply homeschooling is really an impactful thing. And I think the bottom line is you need more people. That's just a fact of the matter. At a time when you can least afford it, you need more people. And your admins, I think, really have to work on hiring more people. You have to cross-train people. We're doing that a lot at our ASC. We sort of had nurses and techs and front office staff people, and they're now all doing everything. And we're trying to cross-pollinate that as well. We are at a financial problem, so you kind of have to restrict some expenditures. But I would suggest that rather than restricting the people you have, I think you need more people. I think you have to give more people less hours, I think is probably the more rational way to approach that. And you also have to just acknowledge this. And I think it's very important to acknowledge that this is not normal for people. This kind of is a battlefield scenario for our people. And people have talked about battlefield promotions, and that's happened. We've just moved someone up that probably wasn't ready to move up, but this is where we are and what we're doing. And you have to kind of get that. And I think you have to acknowledge that with your people as well. So your team is going to be different than your team was. This was a reference, and you can look it up, that really suggests, and it's just a depressing one, that we're not going to be done with this for another 4 years. I mean, some people are talking 1, some people are talking 2. It is not, as I said, going away, and many people think this is going to be measured in multiples of years. Vaccines are coming, as you know. There'll be a vaccine in someone's arm, probably in 2020, but that doesn't mean there's going to be a vaccine impacting community health even in 2021. I'm not quite sure we're going to even have sort of vaccine safety within 2021. In fact, I suspect we will not. There's real questions of the protective effect of vaccines. We don't know that yet. We really do not. We don't have a vaccine that protects people against the common cold, another virus. There's unfortunate politicization of that, which is going to limit acceptance. And simply, the logistics of getting literally 700 million doses of vaccines to people, that's what it's going to take, is monstrous. And you can talk about calling out the National Guard and the like, but those are aspirational. And practically speaking, we're not going to have even if we have an effective vaccine, we're not going to have an adequately vaccinated population for, I'm saying 2022 probably for you. I think what'll be here sooner, and I hope, and we keep talking about every month I do a webinar on this stuff, and we're hoping it's out just next door, just next door. But in fact, there's some depressing news on the saliva test recently. What do we all want is a $5, real time point of care test, right? When you can literally have everyone come in, get a little swab or spit into a little saliva into a tube, and really know who's got that. That will change our game. There's no question about that. That will be a really important thing within our healthcare world and in NBA bubbles and on college campuses and all of those things. But we don't have it yet. Even sort of the Abbott test, which is not really applicable to a private ASC center, nobody can get it or would use it, and it's expensive and inaccurate and not so fast. That is not yet here, but I hope it will be here shortly. PPI still matters. This is another depressing thing. I mentioned gowns are a problem. It's 7 or 8 months into this, and there's still a shortage of PPE. It's better than it was for sure, but we're still all wearing N95s. This was the survey in June, and I'm sure it's still true now. In fact, the number might even be higher. We're still assuming there's a background incidence of COVID in our patients, and I suspect you are too. And certainly for GI procedures, not for office-based encounters, but for GI procedures, I think almost all of us are wearing N95s for all of our GI cases. We may be wearing them for a week or two at a time, but which is not appropriate. And if we had 75-cent N95s like we used to have, we would do this differently. But staggeringly, 7 months later, we don't have that yet. Turning to patients, so that was staff and us and our own safety, but patients are why we're doing this whole thing, of course, and this isn't surprising to anyone. Of course, patients are avoiding care, and you can see that this was a data set that actually should be updated as well, and you can see this really abrupt decrease, a 60% or so decrease in people coming into the office in late March and early April, and that's coming back, but far from perfectly, and the numbers are absolutely down still. We are not, this country and certainly this region are not, we're at a new normal, and we have not come back. People are one, terrified, and two, losing insurance, losing jobs, and are deferring. We know that. There was a report yesterday or the day before about delayed cancer screenings, and I could have put in 6 or 10 slides on the consequence of delayed preventative care, and that's pap smears and mammograms and absolutely colonoscopies as well. Delayed preventative care is going to be we're seeing deaths and we're counting today's deaths, and of course we have to do that, but what we're not really counting is sort of tomorrow's deaths and those consequences. So it's a problem. People say they'll come back. This is a survey the Kaiser Foundation did. Sort of literally half the people said we're skipping care, but of those people, a third of them said, yeah, we'll come back. Everyone kind of wants to. Whether that will happen or not, time will tell. This is super interesting. This was a private group, the advisory board, just sort of asking people what it'll take to get them to come back. And this is, again, a little early. This is June, so things could be different today than they were in June, perhaps. And it's interesting in part because I've told you about the fallacy of all this theater, that we're doing, but it turns out patients buy into the fallacy of that theater. So maybe I shouldn't be so harsh on it. If you ask people what it is to get them to come back in, the most powerful attribute on the list on the right was if everybody had a vaccine, and that's not surprising. If everybody had a vaccine, we'd all be much more comfortable seeking in-person care. But the number 2 on that list was sanitizing the room, and that's a generic term. They perhaps mean making that room safe. What patients don't necessarily mean is sanitizing the surfaces, wiping down the counter that they're not even touching, or the door handle that they're not touching. It means making that room safe generically. And then you can see the list: rapidly testing people, temperature screens, which really probably are not nearly as useful as we do. We could have probably cured cancer with the efforts we put into taking forehead temperature monitorings around this country in the last 6 months. And I think the science is pretty clear. They're not really nearly as effective as we want them to be. You could make an argument that that's just theater as well, frankly. But we're doing it anyway. These are the things patients want. It's important to know that, right? Because you want your patients to come back. So how do you do that? How do you reassure them? You do the things they're telling you to do, of course. And then you got to tell them you're doing it, right? If they don't know you're doing it, they're not going to come back. So is that text blasts to your patient? Is it emails to your patients? Is it videos on your website? We have a whole section on our website. Most people do. Stanford, UCSF have big, giant sections. Here's what we're doing. Even on our sort of small little private website, we have a section of what we're doing to make you comfortable. You got to tell them. You got to tell them what you're doing, and then you have to actually do it. I will just editorialize for 1 sec before we finish up and just say that I think we're in kind of a unique position. People are terrified. I've got an 80-something-year-old mother in South Florida who's quite fearful to simply walk out of her house. And that was fine for a month or two. It's not so fine at 7 or 8 months. But sort of the one thing she trusts are her doctors. She's always trusted her doctors. And that's true, of course, of many of our patients. And I think that gives us a really good opportunity to really role model and show them what can be done and take their fear and give them a positive experience into what I've sort of called their reentry, right? They have to come out. Mom has had to go to her doctor. She can Instacart all her foods, but she's had to go to her doctor. She has all sorts of stuff going on. And I think we can be really important in making people feel safe. And I would try to just think of that. That's who we are in this world. We are there, sort of the ambassadors of this. And I think it's important to take that road. And I think that's us a lot too. It may be our staff, but I'm having a whole lot more I have a whole lot of patients who are calling and saying, can Dr. Stollman call me about my test and the plus minus and the risk benefit? And I'm having that conversation a lot. And it takes a lot of time, and it's kind of annoying to do that 4 or 5 times every single day. But it's important, and just keep in the front of our minds that is what they need, and we're going to have to be reassurers for quite a while. And I think that starts right in the beginning too. It starts with the first telehealth visit when you're talking to them on their Zoom call, and when your staff are calling. Every single contact has to really address these concerns, I think, very proactively. I think it doesn't make sense to wait. If you wait, you're going to lose a bunch of people. I think you have to be very proactive about doing that. And then with the last minute I have, I will just turn very briefly to telehealth because that's obviously a game changer. And I could give a whole lecture on telehealth as well, and I'm not going to. And in fact, I almost gave you a whole lecture on this new transparency and information sharing rules, which are a whole nother problem that are just coming out this month. And the ACG is going to put out some information for you on that. But telehealth is of course giant. Telehealth was here before COVID was here. Of course, telehealth's not new, but COVID has been an incredible accelerator of that. We went from literally 10% of the world using telehealth to now 3/4 of the world using telehealth in a month or two. I mean, an incredible twist. And there's some growing pains with doing that, but I think all the analyses suggest that we did great. Actually, it may be one of the silver linings here is that we pivoted and we figured it out pretty darn fast. And necessity is the mother of invention. And providers like it, patients like it. It is largely a success. And by whatever metrics you look at, I still need to bring someone in rarely, occasionally to look at their tush, because sometimes you just got to look at a tush in my world. But a lot of stuff is not looking at their tush. It's educating and communicating and listening. And those things can happen via telehealth and do happen via telehealth. And on the right is just a graph suggesting that at least 20% of all of our healthcare expenditures could be virtualized. That's a new word, right? Virtualized, or a new word to me. And at least a fifth and maybe a quarter of what we do. And that's a lot of what we do. You're not going to virtualize our endoscopies per se, but really, some have estimated that at least 20 or 25% of what we do is going to be virtualized going forward. And the key component there, of course, is going to be parity. That's a whole nother discussion. But are people going to pay for telehealth? Really, that's the core part of this. And the feds still are, and we're under this what they call parity, meaning they're going to pay the same for telehealth as they would for in-person health. At some point, that's going to pivot, and that's going to start with the feds and the private insurers. And we're going to have I think a heated battle for a X month period where we're really debating what is that worth and what do we pay providers for that. And if you don't pay providers enough, we're not going to do it. And if you do, we're going to do it. And we got to find that ground where I think we can keep telehealth as a tenable thing. There is no doubt patients want it. Patients drive this ship. We're not nearly as important. Again, I'm an advocate. I do a lot of legislative work. Turns out no one really gives a damn about us, honestly, or not very much. But absolutely, the government cares about patients. Patient voice is much louder than our professional voices are. We're felt to be self-serving, of course. Patients are not, and patients vote, and patients are going to clamor for this, and we're going to get it. So what is the future? I don't know what the future is. I told you it's a foggy bridge, and I don't know what's the other end of the bridge. But historically, everybody thinks Abraham Lincoln said the best way to predict the future is to create it, and we're creating our own future. While I was researching that, I actually found an entire controversy whether Abraham Lincoln ever said that or not. And in fact, Alan Kay, who basically created Atari, an interesting guy who created Atari, and that was I'm giving away some of my own biases here, but actually most people said Alan Kay was the guy who said that, not Abraham Lincoln. But I will close with a sort of more practical quote from someone I miss a lot. The future rewards those who press on. I don't have time to feel sorry for myself. I don't have time to complain. I'm going to press on. And I think that's really my take home here is anger, denial. All of those things are important, back to the Kubler-Ross thing, but we have to get to acceptance and moving forward. We don't have a choice whether we like it or not. And that's important. Just a quick shout out to these people who worked with me and did a lot of work on the ACG for endoscopy during the time of COVID. And I'll leave you with my email if anyone has any questions they want to ask me. And I thank you all for your attention today and the invite. Course directors, thank you.
Thank you, Neil, for an excellent talk as always. And thank you for your guidance as well as ACG governor. And we'll miss you. But I do have one question. So in your practice or based on the college's recommendations, are they still recommending kind of maybe some of these lower risk surveillance procedures like small adenomas or low risk Barrett's to wait for their follow-up procedures, or maybe considering FIT or kind of stool-based testing in low-risk patients?
Well, FIT, of course, could be an entire hour long. So, we could have had Samir and Yuri go back and forth on that too, FIT versus colonoscopy. But I think it's very regional. I think it's hard to draw one conclusion. As you know, right now, the Bay Area is moving to orange. We're doing great. And no, I don't think there's any reason to defer those things. In fact, I think there was a real consequence to having deferred those things. And I think here we should be fairly aggressively moving forward. But in Wisconsin right now, they're running out of ICU beds this week. And for sure, the private, the hospital in Madison, Wisconsin right now probably shouldn't be prioritizing Barrett surveillance cases. They should be doing a very different thing. So it's hard to give one answer. It's of course the $1 million question, but and you're going to have editorials on both sides of that. There are a whole lot of people who think we're not moving fast enough, and a whole lot of people thinking we're moving way too fast. And the right answer is probably somewhere in the middle of that. But my answer, which is the question you're asking, is I think it depends on where you are. And right now in Northern California, thank goodness, and I think in large measure due to some good local leadership, not everybody's happy with that local leadership. Some people think that's too aggressive, but the consequence of that local leadership has been that we're in a good place right now. And I think locally, most of the people who are local in this talk should be proceeding.
And in terms of your thoughts and the college's thoughts on pre-testing, we're still testing everyone who's coming into our surgery center and seeing way less than 1%, positivity on these tests, and yet still wearing, N95 and doing full PPE. Obviously it makes us feel safe, makes patients feel safe, but from a cost standpoint, it's quite burdensome. So.
Yeah, I've written about that, and actually we have a thing coming out in the Red Journal at some point talking about it. It's absurd in a way. I mean, it's one thing to wipe down surfaces, which costs nothing and takes 30 seconds, but there's now 4 or 5 series out there looking at pre-elective outpatient endoscopic COVID testing. That's what I'm talking about now. Literally thousands, certainly, if not tens of thousands of series of over thousands of cases, and every single one of those series, it's less than 0.5%. That's what we're seeing, is a tiny number. So we're putting all of this effort and testing, and you're canceling procedures because you don't get the test back and the like. So yeah, you're finding 1 in 200 or 300 maybe, but at what cost, what effort, what restriction of care? I think that's probably not appropriate. And frankly, there's another side to that, which is that at centers you can do that. At Sutter, where I work, they have it internal. They have it, they can do their own, and that's fine. But there's no private ASC in this country that can do that. And that's a tremendous problem. And there are states, by the way, that mandate that. Thankfully, California does not. But there are states around the country that actually mandate pre-endoscopy COVID testing, and private ASCs can't get it. They don't have access to do that. So a tremendous problem. And I would argue, in many cases, a misapplication of resources.
Well, thanks again for a wonderful talk, and thanks to everyone for tuning in.